This is chapter 34, chest injuries. So there's two types of chest injuries that we encounter, generally speaking, in the field. One is an open chest injury and the other is a closed. Open injuries are probably the most common that we see, and this is from penetrating trauma, gunshot wound, stabbing. Whatever the projectile, the sharp object enters the thorax, whether it's posterior like you see in the picture here, or anterior or lateral, and it compromises the pleura, and it compromises and can compromise the lungs themselves. So when this lung loses its integrity or the pleura loses its seal, what happens now is air rushes into this opening created by the projectile, and it starts to fill that side of the chest cavity, and the lung then starts to collapse. And when the lung starts to collapse and air is rushing into the chest cavity, not into the lung anymore, this is called a pneumothorax. Pneumo means air, and thorax, of course, is the chest cavity, so air in the chest cavity. This is again one of the more common things we encounter. Now, why this person has been shot or stabbed, in that process, it can also damage blood vessels in there as well. So a lot of times you'll get blood in the chest cavity as well from the ruptured blood vessels. This is called a hemothorax. In most cases, the ones that I've seen in the field, is most of them are a combination of both. Not that it really affects our treatment in any way of these open injuries, but at the hospital when they do an X-ray, they'll be able to tell what's what in that respect. The problem that we have with open chest wounds is the pressure differentials that create normal respirations. Now, I hope you remember from your respiratory lecture or your anatomy lecture, the way air moves in and out of our lungs is through pressure differentials. So at sea level, ambient air is 14 pounds per square inch approximately. When we take a breath in and expand our lungs, it causes a negative pressure inside our chest cavity, and air rushes in to fill that void. When we're done absorbing that oxygen, we breathe out, we squeeze our lungs down, we squeeze that space inside of our thorax smaller, and air is forced out when we exhale. Well, if you think about it, this person has been shot in the back, as you can kind of see here. He's still breathing, and he's still creating that negative pressure inside his chest. So, but unfortunately, even though air is still going into his nose and mouth and probably into his good lung, air is also being sucked into that hole that you see on his back right there. So air is now entering into this chest cavity, creating this pneumothorax. This is called a sucking chest wound. And you'll hear it suck in, but it doesn't really allow much air to release. And this is due to pressure differentials between inhalation and the exhalation phases. When you go to exhale, it's a lot less pressure. It's more passive than the inhalation phase. So there's less pressure change or differentials. Also, the wound itself can be swollen. It could be partially clotted. It could have bits of tissue partially blocking the hole. And it kind of works as a one-way valve. It lets air in, but doesn't let it out as effectively. So I'm sure all of you have probably at one time or another pumped up a bicycle tire. And you know that you can pump it up 60, 70, 80, 90, 100, 110 pounds because air can be compressed. So basically, think about this guy as a bicycle tire. Air is going in, but it's not coming out very effectively. Now, when we encounter someone who has a penetrating wound to their thorax, the first thing we do is apply our gloved hand over the wound to minimize any further air entering the thorax. Then we're going to call for our partner to get some type of an occlusive dressing. And this could be something as simple as a plastic bag from the trash can, or from one of your sandwich bag from your lunch, whatever you might have, and some tape, some kind of three-sided, some kind of duct tape to create this three-sided occlusive dressing. Why three sides? Well, This is a sucking chest wound. We don't want air to get in, but we want air to get out. So when this person takes a breath in, the negative pressure causes the seal to seal against that wound, but when they go to breathe out, it allows whatever air can come out to escape out that fourth open side. Now, the problem with three-sided occlusive dressings, as you see here in this picture in the upper left side, is it uses tape to hold it in place. And you can only imagine if someone were to be shot in the chest, as you see here, they might have really sweaty skins. And this tape's just not going to stick to these sweaty skins. So if you have this, if this is all you have, well, that's what you use. But what's happened over the last like 10 years or so, we've come out with these chest seal products. Hyphen is just one of the brands that we happen to use here in the city of San Diego. And you can see from the picture on the lower right side, it kind of looks like a big defib pad, and it has these channels built into it. So it has sticky parts and it has non-sticky parts. And what's nice about the Hyphen or similar products is they're just as sticky as defib pads, and they stick to sweaty skin. So when you open up this little kit, you open up the Hyphen package, you get one chest seal, and in the middle is you get a little bit like a 4x4 gauze, and you just wipe away the excess blood, and you wipe away just a quick wipe of the sweat and blood, and you slap this thing on, you center it on the wound as you see in the picture, and it sticks. And it sticks really, really well. And it still provides that ability for the person to exhale some of that air, and it still blocks air coming in. It's an amazing device. But when in doubt, you use what you have, essentially. Now, according to your textbook, application of either of these devices is supposed to be at the end of the patient's exhalation phase. That means the person breathes out, and just before they take their next breath in, you're supposed to slap this on this wound to minimize any further air getting into the thorax. And it makes sense. The only thing that doesn't make sense about it is if you think about it, if you've just been shot in the chest, you're probably breathing pretty fast, 30, 40 times a minute. So you might not be able to coordinate this, ideally. Just do the best you can, apply the chest seal device, apply your occlusive dressing, whatever you might have, get it covered. If you can coordinate it, that's wonderful. But realize it might not work out in real life, so to speak. Now, closed chest injuries. This person here was in some type of traffic accident. You see they have seatbelt abrasion across their chest. So it looks like they were the driver of the vehicle. And all kinds of internal injuries could have occurred, liver and all kinds, lung and heart and all that, but also rib and possibly the clavicles as well. If you think about it, if she were to break her clavicle or snap a rib, then the sharp edge of that rib or the clavicle or any other bone could penetrate the lung and collapse the lung, creating a pneumothorax. It could also, these injuries can bruise the lungs and have all the other kinds of problems as well. And so, with these, it's the same problem. They can still develop a pneumothorax. They can still have a collapsed lung. And of course, the best way to tell is to listen to their lung sounds during the primary assessment. What you might notice is there's a mechanism like you see here in the picture. So this person's been in an accident. You see this injury to her chest. You're concerned about, this could possibly be some kind of lung involvement or chest involvement. So during your primary assessment, you'd listen to the lung sounds. You get a pulse oximetry reading. And what you might notice is slightly diminished lung sounds on the left side. And you might also notice that their oxygen saturation is below normal, maybe 90%, maybe 92%. And then what you notice is you ask your partner to put them on oxygen, and you put them on a non-rebreather mask, and you notice the saturations don't go up much or not at all. Because right now, their left lung is collapsing due to the puncture, and the only oxygen exchange is in the right side,
and it just can't keep up with the needs. Also associated with this is if they do have fractured ribs, they can get what's called a flail segment. And a flail segment, the definition is 3 or more ribs broken in 2 or more places. And it creates this loose area in your rib cage. And this area is free floating in comparison with the rest of the rib cage. And it causes even more problems, which we'll talk about here in a couple of minutes. So causes, again, this could be blunt force trauma. It could just literally be the, the chest gets hit so hard the lungs pop. I've seen that in the field. It's more than likely though, some type of broken rib or I was just recently on a bicyclist who crashed and his clavicle fractured and penetrated the apex of his lung, causing a pneumothorax. So they're pretty common. Causes, signs and symptoms, kind of the same as with the open as well. They're going to be short of breath. Their saturations will be low or lower than normal. You might hear diminished lung sounds on the affected side, or even absent lung sounds on the affected side. And then again, when you apply oxygen to them, they probably will not get much better. The saturations will not rise or rise at all, depending on the circumstances. Now, when it comes to both the closed and open chest wall injuries, we talked about the pneumothorax developing. We talked about the sucking chest wound. And so what happens is you arrive on scene and this person's had some type of mechanism causing one of his lungs to collapse. And either the sucking chest wound is not being treated effectively, or maybe it's been a while since the initial accident occurred, or there's been changes in the patient. But what happens is this air builds up inside the chest cavity. And it builds up, like I said, like a bicycle tire. Pressure increases more and more and more. It's coming in, but it's not going out. Eventually what happens is the pressure on the affected side starts to push the heart and the good lungs to the opposite side. So if you think about the heart itself, the heart is in the mediastinum, and it literally hangs on the aorta and the vena cava. It's kind of like a Christmas tree ornament hanging there. And if you push the heart over to the other side, you move the heart over towards the good side, what you're doing is you're kinking the vena cava and you're kinking the aorta, and you're effectively reducing the blood flow to the heart. And if you reduce the blood flow to and from the heart, you reduce the person's blood pressure. Also, the pressure inside the thorax, being like a bicycle tire, puts pressure on the muscle of the heart, and the heart cannot pump as effectively, as strongly as it normally could. On top of all that, the heart is now being pushed over into the good lung, causing the good lung to malfunction as well. So the signs and symptoms of a tension pneumothorax developing is this person probably initially already had shortness of breath. They probably already had a low oxygen saturation level, but their vital signs were stable. Their blood pressure was probably fairly normal. Their heart rate was high, but that's not abnormal. Their skins were probably pale and cool and moist. They're probably fairly stable patients. But now as their perfusion starts to worsen because the heart's being affected, what you're seeing now is cyanosis, altered mental status, uh, severe respiratory distress, a marked decrease in oxygen saturation levels. All these things over a few minutes, people start to deteriorate, and this is telling you that this pneumothorax is developing. Now, if this is an open chest wound and you have applied an occlusive dressing, if you recognize this tension pneumothorax developing, you can release the dressing. It's called burping the dressing. It's per S139 in your county protocol. And what this will do is if there is any built up pressure in there causing this tension pneumo, which more likely there is, that will allow some of it to escape. You'll actually hear it make a little sound coming out. problem with all this is again, you know, your book talks about when to release the dressing. I mean, ideally, you would want to release the dressing just before the person takes their next exhalation, their next out breath, so to speak. Because then, as you peel off the uh, the occlusive dressing, and as they breathe out, their lungs, they squeeze that air out that hole, it makes it more effective. But again, we're back to this whole thing about, you know, if they're breathing 40 times a minute, might not be all that practical. So again, do what you can. Now, if this is a closed tension pneumo, you can't do much about that, and they do develop in those situations. If it's an open tension pneumo and you burp the dressing and it doesn't help the patient, they need advanced care. So you need to go to a paramedic unit or to a trauma center or any emergency room, I guess, if you had to, because it's kind of an ABC issue. And they'll do what's called a needle chest decompression. I want to show you what this looks like. You guys can't do this. It's not within your scope. But I want to point out that if you recognize this, you should go to the closest ALS capable unit, whether it's a fire truck or an ambulance or even a hospital, to get this person needled. So I'll show you this, what it looks like, if it runs, hopefully, and hopefully it does. There's your ad, of course. Just going to skip ad. So what you're going to see is the first thing you're going to see is the inside wall of the thorax. You'll see there's a kind of a pink wall there, and the lung is actually below the level of the camera. The lung isn't, so that's just the wall of the thorax. The needle's coming in right there. That's the catheter. It's releasing that pressure, and now here comes the lung. As that pressure gets released, the needle is withdrawn, the catheter remains in, and as that pressure gets blown out of the thorax, the lung reinflates. And this is what we're trying to do when we are releasing that pressure, whether it's by lifting the dressing or whether it's by having a paramedic or a doctor insert a needle in the chest. We're re-expanding that lung so the person can, you know, use that lung to ventilate. It's a pretty amazing bit of photography here. I was quite impressed. So there again, that's your bicycle tire. And again, you want to deflate that bicycle tire because it's putting pressure on the heart and pressure on the other lung. So when someone has a chest wall injury, anytime you encounter anyone who has any kind of blunt force or penetrating trauma to the thorax, whether it's anterior, posterior, or lateral, during your ABCs, you should be getting a pulse oximetry reading and lung sounds immediately on this person because they could have a pneumo developing. And the sooner you recognize it, the sooner you're able to prevent it maybe from turning into a tension pneumo. Now, I talked earlier about flail segments, and the definition of a flail segment is, again, 3 or more ribs broken in 2 or more places. Anyone there who's ever broken a rib, I know I have, and it's really painful. It takes a really long time to heal. Even just 1 rib interferes with your breathing. 3 or 4 ribs, you can only imagine what it does to your ability to take a breath in. Another big problem with this is this section that's floating free now. It actually moves opposite of the rest of the chest wall. So when you were to take a breath in and the chest expands, this little area that's flail gets sucked in. And as you breathe out, your chest wall goes back to normal, but now this little flail segment pops out. So it's called paradoxical motion of the chest. So opposite, as one side goes in, the other side goes out. And it's kind of a late sign. So initially when this happens, the intercostal muscles try to compensate by tightening up. And they do a pretty darn good job of this. So they're not easily recognizable in the field. You're going to be palpating, you're doing your IPA on the chest and palpating the chest wall, feeling for crepitus and tenderness and these soft spots. And if you feel around, you might be able to feel it. But if this person is still compensating for this flail segment, you might not, you might miss it. Now, as this person starts to decompensate, as their oxygen saturation starts to drop and they become more hypoxic, those muscles aren't going to work quite as well, and that's when you're going to see this flail in and out, opposite paradoxical motion. The problem with this paradoxical motion of inspiration versus expiration is, normally we move air in and out by these pressure differentials. Well, if one lung is expanding while the other one is contracting and they're going back and forth, so one lung is getting bigger and one lung is getting smaller, opposite to one another, all that's happening is air is going back and forth between the two lungs. It's not going out the trachea, out the mouth, and air is not getting back in from the outside world. All this bad air is just going back and forth, and it's not going anywhere. So if you encounter someone who has an obvious flail segment with paradoxical motion, the only real treatment for this is bag valve mask ventilations. And what that does, we're assuming the lungs are intact in some way, is if we inflate the lungs with a bag valve mask, it forces both lungs to move in and out at the same time, and it allows us to exchange gases and get air in and out effectively, bag valve mask. So the treatment for flail segment is BVM ventilations. It comes down to that. Now, pulmonary contusions, you all know what a contusion is. You've had bruises before on your skin. Same thing, basically. You bumped against something, you damaged your capillaries and they're bleeding, leaking. Same thing here, blunt force trauma to the chest, the lung has been bruised, it's bleeding, and the area has this micro bleeding going on cannot exchange oxygen very well. You might get lower than normal saturations with this. There's going to be a mechanism, blunt force trauma to the chest, maybe a steering wheel or got kicked by a horse or something like that. They're going to have a lot of pain. They could have some cracked ribs. You might hear some crackles in their lungs. Depends on the circumstances. I mean, if they have a serious enough injury to cause this, they probably have other injuries as well that are probably more critical, in the sense that more treatable, like right now and then during the transport. Traumatic asphyxia. So I'm sure some of you have gotten punched in the stomach, or you fell and hit your stomach and got all the air knocked out of your lungs, and you couldn't catch your breath for a couple of seconds. Well, this is like that times 1,000. So this is a person who gets the blunt force trauma to the steering wheel, just slams into the steering wheel, high-speed car accident, unrestrained patient. And when that steering wheel hits their chest, it compresses their chest, and all the air expels, obviously, from their lungs. And their lungs can actually collapse, or sometimes they won't collapse, depending on the circumstances. But what happens is there's a lot of blood in the lungs themselves and in the heart. And all that blood in the lungs and all that blood in the heart just get pushed up into the shoulders, neck, and head. And they get this bright, like a purpley smurf looking color to their shoulders and to their neck and to their head. This gentleman right here, he's after the fact. He's changing color, but you can see that all those are all ruptured blood vessels caused by that sudden push of blood up in towards the head. Again, it's C-spine, airway control, suctioning. Listen to their lung sounds. Make sure that both lungs are still functioning. They will, reinflate themselves. Bag valve mask ventilations, of course, if that's appropriate, and of course a trauma center. Cardiac contusions. Again, there's a contusion again, the bruise to the heart. Remember, the heart is a muscle, and the muscle contracts to pump blood, and there's electrical conduction that controls this. So if you have an area of the heart that's bruised, it can interfere with the actual cardiac rhythm by disrupting the electrical conduction of the heart. So you have a young, healthy, 20-year-old patient. They crashed their motorcycle and now they have this grossly irregular heart rate, or heartbeat, should I say, and they have a mechanism that says that they hit their chest and there's bruising to their chest and maybe there's a cracked rib and maybe there's some abrasions to their chest. This dysrhythmia, this irregular heartbeat might be due to the bruising to the heart. Nothing you can really do in the field for this other than treat them symptomatically, oxygenation, C-spine, rapid transport to the hospital. Now, pericardial tamponade. So we know that the pericardium is the fibrous sac that the heart is suspended in. The heart is flexible, it pumps blood. The pericardial sac is not. This is usually caused by penetrating trauma to the chest. It enters the chest wall. Whatever the sharp object is, whether it's a bullet or whether it's a knife or an arrow, it penetrates the pericardium and it causes bleeding inside the pericardial sac. And because as that blood pumps out, as the blood has nowhere to go because the sac can't expand, that blood starts to put pressure on the heart, and the heart can't pump as effectively, it can't expand and contract as it normally does. So what happens is you see this what's called a narrowed pulse pressure. Remember, the definition of a pulse pressure is the difference between the systolic and diastolic blood pressures. So normally 120/80, so that would be a pulse pressure of 40. This person has pericardial tamponade developing. You might see something like 110/100, very narrowed pulse pressure because the heart can't really expand and contract to create those pressures that, and then now it's almost like everything's kind of equalizing out essentially. You might also get what's called pulsus paradoxus, and you can get this also with tension pneumothorax as well. It's caused by the pressure inside the chest cavity when the person breathes. So if you're feeling this person's pulse, who has pericardial tamponade, when they take a breath in, you might notice that their pulse disappears. When they take a breath out, it seems to reappear, and this is because there's more pressure and less pressure being applied to the heart. And as that heart is relieved of pressure, it starts to create a beat again. Now, lastly, Commotio Cordis. So Commotio Cordis, this is blunt force trauma to the chest. I know some of you might be football players, or maybe you played in high school, or you played in college, or elementary school, or Pop Warner, or something like that, or soccer, or hockey, or field hockey, or basketball. You might have noticed on the sidelines your coach or your sports medicine person had an AED available. And the problem with all this is this does happen. We get a couple of these every year in the county of San Diego, and it's a young, healthy child or an adult. They're in some type of sport, and they get slammed in the chest. And what happens is you can see this picture on the lower left side. This is called a sinus rhythm. This is the electrical conduction of your heart when it's beating normally. Those positive deflections, the P wave, the R wave, the T wave, those are all things that are happening in your heart. The P wave is when your atria contract. The R wave, or the QRS wave, is when your ventricles contract and pump blood to your body. And the T wave is the resetting of the whole system. Now, that kind of flesh-colored line that runs down the near side of the T wave, this is called the relative refractory period, because your heart has to reset. And during this very narrow millisecond period that you see there, if you were to be struck in the chest at that one point in time, you could go into ventricular fibrillation. What you're doing is that 30 or 40 pounds of blunt force trauma to the chest is disrupting the electrical conduction of the heart, and it sets your normal rhythm into this chaotic V-fib. And 30 or 40 pounds of blunt force trauma is not that much. A fist can do this. A good hard blow to the chest with someone's fist at the right time can do this. This is called the R on T syndrome. So you have this sudden spike caused by the blunt force trauma at the wrong time. Now,
the fix for this is an AED. These are young, healthy people with young, healthy hearts. They don't have heart disease. And if you can get out there and you can start compressions and put the AED on and go through your prompts, I almost guarantee 9 out of 10 times this person is going to come back in the very first shock, because it's not a disease uh, problem. It's purely just this kind of case of bad luck today. So don't be surprised you get called out to a sporting event for this. Again, these trainers, the coaches, the crews are all aware of this. They probably will have already defibrillated this person before you got there. But they need to go to the hospital, need to get evaluated, and you should keep the defib on them all the way to the hospital in case they were to rearrest. So it seems very unlikely. I think we're done here.